Hello, I'm Patrick Dunn, and I'm pleased to introduce you today to Michael Carroll. Michael is the Director of Respiratory Services at New York City Health and Hospital at the Harlem campus. I should point out that New York City Health and Hospital is the largest public health system in the United States, serving over 1 million citizens of the greater New York area across the 5 boroughs. Michael, thanks for finding time to join us today, and welcome.
Thanks for having me.
Now, what we're going to do is spend a little time having you share with us how you and your department reacted and responded, I guess, in a positive way to the COVID-19 pandemic. And of course, New York City has been in the press throughout this whole pandemic because of the fact that you had such a large influx of patients treated for COVID-19. Now, as we talked about yesterday in our brief discussion, every hospital had an emergency preparedness plan. But pre-COVID-19, it was all predicated on one event with a defined period of time. This is unlike anything else. This is now going on. We don't know when it's going to end. And the question is, what has been the overall impact to the hospital in general and to your respiratory care department in particular in terms of the impact of the COVID-19 pandemic?
The actual, during the pandemic, our workload significantly went up. I mean, every patient was on oxygen, ventilator load tripled, every BiPAP and every high flow was used. About a quarter of my staff, the 13 people, got sick. We were lucky we were able to get people from other states to come as temporary workers. And then it was just a struggle. It was really hard. Post-COVID, it seems that people are hesitant to come back to the hospital. And there may have been some change in the demographics. Normally July is a very busy month, and it hasn't been that busy at all.
So there's some residual reluctance on the part of patients who are not COVID positive to come back and seek normal healthcare services that they would have otherwise been able to access prior to your redirecting away from the outpatient and for the elective surgeries.
Yes, we see that patients aren't coming back as quick as they can, as they would have.
And you have a lot of chronic care patients that you're worried about. You mentioned yesterday, when we were chatting about these patients with COPD and asthma, especially asthma in your neighborhood. It's a real challenge to get these people back into the system.
Well, part of it is that they're resistant, but they've also changed their activity right now. I mean, some of them aren't going out that much. Maybe kids that were going to school the attacks were being triggered more at the environment at school than at home. There's less activity on the streets. I mean, I just saw a study that said there are less premature births occurring because I guess mothers aren't working as hard as they were before. So I think some of it is people afraid to come back, but also some of it is people aren't working at their jobs. They may be working at home. Their total lifestyle has changed. So maybe some of that is affecting too. Also, there's not as much celebrations on the streets. There's less driving on the streets. So there's less trauma. I mean, we've still gone through our amount of gunshots and stabbings, but I don't think it's as bad as it's been in previous years.
You mentioned, Michael, unfortunately, that 13 of your staff became infected with COVID-19. Hopefully they all recovered without too much of an incident, but you had to rely on travel therapists. How did they integrate with your department? How did your staff handle the fact that they had new people coming in and you've already established protocols for your own in-house staff?
So when I first came to this department, it had very few full-timers and a lot of agency people. So the culture of the department was designed to be able to quickly train someone and try to get them to become part of the department. So it was something they were used to. And then when the people came in, first of all, they're so appreciative to have extra people on hand. We were able to quickly train them, and it got to the point where if you didn't know the staff, you wouldn't know the difference between a agency person and a staff person. They just got into the flow. I mean, what we did was we had them focus on like certain areas instead of having trained them through the whole hospital, and just get them very accustomed to that. And it worked out really well. I mean, everybody became bonding, a lot of friends and all that. A couple of people actually wanted to stay. Unfortunately, our non-COVID temporary rate isn't very high, so
Mhm.
discouraged them.
Mhm.
But it really
Now,
worked out well.
that sounds good. Now, understand you shared that you were basically kind of an absentee director for early on, and yet you were able to continue to direct the department. And the big issue you challenged yourself was PPE equipment, especially with other hospitals in your system, trying to take care of their needs. But yet you indicated that you really didn't think you had much of a problem getting the required protective equipment that you needed for your staff.
Okay, well, I was stuck at home because I had some health issues, but I was allowed to work at home. So I actually was working harder at home than I was working here. Um, and it was a battle every day to get equipment. We were fortunate that we had a very good incident command center, so they helped out a lot. And being part of the system, our system was able to help us also. I mean, things were rationed. I mean, at the beginning, N95s were a one week usage. You got one once a week, and that was it. Um, but we were able to secure a lot of supplies from our system also. And the state of New York also was trying to make sure that supplies were getting to our health system.
Now, one of the issues that you also mentioned with the Incident Command Center was the daily reporting that was required for all departments, including yours. How valuable was that in the long term in terms of, as you look back, about the success of your RD department to transition to these new realities?
Well, we had a dual daily reporting because we had a daily report to our Incident Command Center. We also had a report to our system-wide command, who then had a report to the state of New York, and our own command center had to report to different sections of the state of New York. Um, and it allowed us to understand exactly what was going on. And now we still are doing this reporting daily. So we understand exactly what new patients are going in, what equipment we're using every day, and what adjustments we need to make. And also how much staff we need.
All that data will be a great legacy when people want to research years from now the direct impact of COVID-19. So you're setting a legacy in terms of future researchers to be able to mine that data, I would imagine.
Well, the data has already helped us. During the COVID crisis, our oxygen supply system was pretty much overwhelmed to the point where they had to bring in a whole extra bulk system and connect it into our hospital supply system. So now, post-COVID, we're planning a new hospital supply system, and we used all the data that we were producing to actually calculate our usage during that time. So we're able to figure out, oh, this is how much we're going to need. So it's already helped in that sense.
Mm-hmm. The involvement of your RT staff in protecting the providers, respiratory therapists, nurses, physicians, for what are now known as aerosol generating medical procedures, such as intubation, extubation, bronchoscopy assist, non-invasive ventilation. You mentioned that you talked to your patient safety officer, was keenly involved in setting up those standards, Michael. How was respiratory involved in setting the standards and the protocols?
Okay, so the first thing they were worried about the most was actually the manual resuscitators, because when patients came in, that could spread aerosol all over the place. So we decided that any manual resuscitator would have to have a filter and a PEEP valve on it. So we actually put filters, and we also, because of the type of patients that were coming in, we added PEEP valves to all of our manual resuscitators, because most of these patients needed a high PEEP. So all of them had PEEP valves on them. So we filtered that. We made sure that, well, our ventilators were always filtered. Sometimes the transport ventilators didn't put filters on, so we made sure those were filtered, put filters on. The BiPAPs, we started putting filters on those. We didn't do that in the past, and we started putting filters on that. For bronchoscopy, first for suction, we always had inline suction, and that'd be the only way that we had patients suction. Um, Bronchoscopies, intubations. First of all, we would limit the amount of people in the room, um, and just make sure they were all wearing their proper PPE. So we transitioned most patients to other forms of oxygen. The trach patients we put on high flow. A lot of the information from high flow was telling us that it really didn't produce much of an aerosol, so we used that. Also, we had a simple mask, not a simple mask, an oxy mask,
Right.
which is the main mask we use for delivering oxygen in our hospital. The therapists at the beginning were worried because there are 2 holes on the side that there would be aerosol transmission from that, even though that's not really the case. But when we first set up the oxy mask for COVID patients, they were actually putting surgical masks on top of them, which really didn't need to be done for the transmission of aerosol, but it turned out to allow us to create a higher flow with our VO2. So patients that didn't do well without the surgical mask actually started doing well. And we found out that we had a test to figure out the patients were getting better by removing the surgical mask. They didn't desat when we removed the surgical mask. We realized they were starting to get better. And we had a lot of patients that we didn't end up putting on vents. We did have a significant amount of vents, but there were a number of patients that went on high flow BiPAP and oxy mask. We have about 100, 120 med-surg beds, and almost every single patient was either on an oxy mask or a BiPAP or high flow, and they were all on 15 liters or more. So a lot of those patients with COVID that never needed a vent, and a significant amount of them survived.
We're ahead of the curve, Michael, because today now we recognize putting them on a ventilator early on is probably not the best strategy. We should try and manage their hypoxic respiratory failure non-invasively, which is what you obviously have hit upon. And in terms of the staff training, everybody probably recognized these were relatively innocuous procedures in terms of the providers prior to COVID. Our focus was on patient safety. Now, of course, there's the potential exposure of the provider, the caregiver, that you have to work with as well. How did your staff adapt to the fact they needed to protect themselves for once were innocuous procedures?
Well, one of the things that was done was actually infection control went around and actually did drills on donning endorphin to make sure that everybody knew exactly how they should put their PPE on. So that was the first step. And I think that we constantly kept people aware of, not to cut any corners.
Mhm.
But I think that after the first staff member got sick, people started realizing that this was really serious, and if they touch anything, they had to make sure that they were protecting themselves. Well, once in a while, I would have a telephone conference with the staff,
Mhm.
and I would keep reminding them, you constantly got to wash your hands. You touch a piece of equipment, you got to wash it. Any piece of equipment can't leave the room until it's thoroughly scrubbed with the bleach wipes. We were making sure that, we're banging into their head. They would not go anywhere without understanding the importance of protecting themselves.
And that was constantly reminded, very, very important to keep awareness 100%. Now, compare and contrast that with the fact that some patients required aerosol drug delivery. Now we've upped the ante because we now have aerosol particles coming out of a device that's going into the patient, but also coming out into the environment. So how did you attack that next challenge in terms of protection of the caregiver?
Before the crisis got bad, my medical director met with me and said, look, this is going to be a problem. So we had discussions with the emergency room and other physicians to try to make some determination. First thing we decided was to try to use as much MDI as possible. However, we realized that created a problem of an MDI shortage. So then we had to focus on putting the MDIs in the most needy area, which we felt was the emergency area. And then on the floors, we'd have to focus on using medication nebulizers. But we decided that we'll only use medication nebulizers that can be filtered. I came from a hospital where all we used was Arrow Eclipse. And now I'm here trying to introduce it because I felt it was an efficient way to deliver aerosol. When this crisis came, they were so appreciative to have any type of device that can be filtered, that can protect them. They were able to accept it more readily. Now we're actually working with the sales rep, and she's giving us material that we're giving each staff member to have on how to approach a patient, address them, and explain that we're going to have these much shorter treatments. I think with breath actuated, they're going to be like 3 minutes, continuous 5 minutes, but you're still going to get the same dose. But at the same time, it's going to be a much safer environment for everybody. And they have gotten to the point where they don't ever want to consider using another type of nebulizer, a non-filtered nebulizer.
Well, that's really nice to hear because there is some advantages, obviously, both to the patient in terms of reduced treatment time with no change of efficacy. At the same time, a higher level of confidence in the terms of the respiratory therapist that they're going to be protecting themselves and others in the environment as well. So it's a win-win situation, both for patient safety and for caregiver protection.
Yeah, that's the way. The staff has done a much better job, and they're very happy with the way things are now.
You mentioned a term yesterday, an opportunity to be taken advantage of. And it seems like that's something that's been kind of a thread throughout your response to this pandemic.
Well, I always wanted to make the environment safer. That has always been my goal. The COVID crisis gave me the opportunity to look at things I really wanted to clean up. Because I remember when I was a staff therapist, I would come home wheezing every night. And until I became a supervisor and stopped giving all those treatments, I realized that all of that medication I was breathing in was probably wreaking havoc on my lungs. So this was a great opportunity to try to make things better. One example is the Arrow Eclipse. Now they see how much safer it is for them. They will not go back to any other nebulizer.
I can see where your oxygen utilization really was much greater than you anticipated because you were treating patients with oxygen therapy to try and get them out of their hypoxemic respiratory failure. Now, you also mentioned using the breath-actuated nebulizer. One of the issues we discussed previously was the fact that when you look at aerosol delivery of medications, you enter another realm of practitioner protection because of the environmental contamination with the nebulizer. And one of the first things that people say is eliminate unnecessary treatments. And you had a kind of a nice way to answer that yesterday. How do you avoid unnecessary treatments at your facility to make proper use of your resources?
Well, we're lucky in the sense that our medical team in the hospital is pretty good at not ordering a large amount of treatments that aren't indicated. So we're lucky in that sense. And a lot of the patients are not only, they make sure they're covered with not only a bronchodilator, there's always some type of controller that's added. Also, the staff will work with with the physicians in assessing patients. And if they feel there are issues, they'll work to either, if we feel the patients aren't getting enough treatments, we'll add treatments. If we feel they need less, we decrease them. We actually have some assessment tools that not only have we adopted, but like the pediatric patients, that's how they determine all the medications based on a pediatric assessment tool. So that's one of the ways we've been limiting medications on the floors.
So another part of your logistical challenge was to work with pharmacy to make sure you had a supply chain that was full of the MDIs, even though there was a shortage probably throughout most of the Northeast.
Well, pharmacy would actually give us a report every day of the quantity of MDIs left and actually all the drugs. So we know what we had to deal with, and we know when we went to the floors what we had to convince the physicians of. But the physicians were also giving this too, because this was part of a the command center getting information out, making sure that everybody knew what resources we had. And, you know, we were constantly communicating with um, all the medical team to make sure they understood what our problems were for the days. I mean, there were days we were starting to run an event circuit, so we had to figure out our next plan of what we were going to do if we were running an event circuit. So, I mean, we were running out of our conventional event circuits, but the state had given us the LTVs, so we had to switch some patients to the LTVs because we were running out of circuits for our RVs. So we ended up doing things like that until we were able to get more resources.
One of the issues that came up with respiratory therapists, not in your facility, but a lot of shortages of qualified physicians and nurses. What happened in some hospitals, they redeployed physicians and nurses from non-intensive care settings into the intensive care unit. And they haven't had that experience since their training. And here they wanted the respiratory therapist to teach them how to use the ventilator. Any issues with that? Or I guess I can answer, there were no issues, but your staff actually stepped up more so than I would have expected. Could you describe how they kind of work with you and your medical director to make these physicians and nurses comfortable with ventilator safety?
So prior to COVID, we've always believed that the medical staff, doctors and nurses, needed to understand ventilation. So all of the critical care nurses, and actually we do the floor nurses too, get a full in-service on the ventilator. They don't want to know how to adjust settings and all that. They just need to understand what the ventilator is doing when the ventilator looks like it's not working and what to do if there is an alarm. We also used to give that in-service to the new house staff as they came in. So my staff was already trained in how to do this. So when COVID came and new people came that weren't familiar with it, we were able to do on-the-job training right away and make sure people understood what they needed to know.
Yeah, another example of having systems and processes in place that you could leverage and then refine to the new order that was introduced with COVID-19. You mentioned your medical director, how important that person was going forward. And I can't emphasize that enough because the common theme back, again, interacting with medical staff, physicians, and nurses, was a medical director who actually really advocated what the role and responsibilities of the respiratory therapist would be.
Well, I'm lucky. I have a great medical director and also a very good physician staff in this hospital. We have a good relationship. The patient safety officer is actually a physician also, so we have a good relationship with her also. But my medical director, first of all, before things got bad, she was making plans, and they have our system has a critical care council.
Right.
They had met before to actually play things out and also make sure everybody was researching and looking to see what was going on in other parts of the world where they've already run into the problem. So when we started getting cases, we already had a good amount of knowledge to know where to start from. Like we knew at the beginning that we had to start these patients on high peeps right away. I mean, they understood that quickly. High FiO2s, high peeps, and not wean them down. Like normally, if we put a patient on a high FiO2, we would wean them down within the first 24 hours. Here we understood this is not something. And any issue that came up, me and my medical director were dialoguing all the time. Even though I was home, I was either talking to her on the phone or she was texting or emailing me every day. And so we knew each other's problems. And when there were issues that came up, we worked on them together.
One of the challenges, of course, as you mentioned, information from around the world, because it is a pandemic. And sometimes the information that's coming out is clinically valid, but it hasn't been vetted. But you had that critical care council that would vet the information, albeit sometimes not with a lot of data, but yet, you know, showing that there is a positive outlook. So that critical care council was one of your ways to vet the information to make sure that it passed muster in terms of scientific accuracy.
Well, I think it really helped because, when, physicians know they're not alone. And when you're all together as a team, everybody brings different expertise. Some people are strong in research, some people aren't, some are strong clinicians, and it really helped. I think the whole system was able to manage as well as it can because they were able to pool their minds together and work on the process together. And it also helped in the sense of when one hospital struggled, the other hospitals were able to help that hospital out. I know that on the news, when New York first ran into its problem, Elmhurst Hospital really struggled the most. And a lot of the other hospitals were able to pitch in. Little bit of staff sent over there, not much because everybody's ready for staff, but we were able to send some equipment over there to try to get them over the hump also. So, I mean, it was a benefit of having a system that was able to work together to keep all those communication channels open.
One of the other issues affecting the healthcare workers on the front line, doctors, nurses, respiratory therapists, pharmacists, was what they call vicarious trauma, dealing with very, very sick people, high mortality, high morbidity. It takes a toll, even on the most self-assured professional. What resources were available to help handle staff stress, potential burnout, or concerns about their family? I mean, this is a high stress situation that I'm sure had some interest in terms of your hospital system's well-being.
Okay, so the health system has an employee assistance program, so that can always be used. But in addition, my hospital had set up way before COVID, when I think like 1 or 2 years ago, when we realized that some of our residents were starting to stress out a little, we created a healthy healing program, which actually created a team and a phone number, and there was a group that would actually just show up if there was any problem. Anytime there was a trauma where people were affected, they would have post-trauma meetings with the staff to try to make sure there weren't any issues. During the pandemic, we set up an actual room for people to go and relax and also to talk to people. As a manager, we were told during our daily huddles that if there was anybody that had a problem, these are the steps you needed to take, and also watch to see if you see any signs and symptoms of problems to try to get this team to come over. And there were also, we used to have, every day we would send emails out to the staff that were called Harlem Required Reading. And part of them were relaxation suggestions, also advertising on healthy healing and all that. So I think we covered that pretty well.
I think you said your CEO also sent out highly required reading memos to entire hospital staff.
Yeah, that's what she did every day.
Yeah. All right, let's take a look at the last 3 or 4 months now and give you a chance to reflect, or maybe 4 or 5 months, I should say, on what you're most proud of in terms of how you, the RT department, and your hospital in general responded to the pandemic known as COVID-19.
Okay, so individually, I mean, I've always told my bosses that the department should be able to run well when the boss isn't there. And I was proud that I wasn't physically here, but the department really ran really well. Everybody stepped up. There weren't any problems. So, and the staff shined. I mean, even when we were at our lowest staffing levels, everybody was able to meet at least the minimum demands, and everybody worked together. Hospital-wide, we were able to manage. I mean, it was a difficult task, very limited resources, and the institution was never really funded well to begin with. So we were able to get through without any major problems. I think the staff really came together well. And I think that's our strong point. And I think from it, it's going to make the institution much stronger because we learned a lot from it. We learned things that work, we learned things that don't work, and we learned things that we need to fix. So it really, really helped us a lot in that course.
One of the new developments, as you mentioned, an opportunity to be taken advantage of is virtual care, especially for chronic medical conditions post-COVID-19. Have you started using any telehealth services? And if so, do you expect that to increase going forward?
Well, the hospital had some virtual care before, but it really significantly grew at the end of the crisis and now. I'm hoping at some point, like we have a therapist that goes to the outpatient clinic once a week, though we haven't continued that post-COVID yet. At some point, we might be able to have a telehealth part of that. I mean, right now there might be a billing issue with the therapist being alone. I think they will probably now have to go to the clinic to do the education, but at some point, I'd like to see that become a telehealth function, because I think that would help us better manage the patients. Because the goal, well, we've learned that it was a very big positive to keep educating these patients at the clinic. It really reduced the readmission rate, because a lot of these patients need constant reinforcement, especially on how to take their meds. And also we found out that sometimes the physicians were prescribing meds that just the patients weren't able to take.
So you have a large asthma population being inner city, I would imagine. So that's another challenge, is to get them back into the system, because as you mentioned earlier, they're now fearful of going to the hospital because of the COVID-19, but yet the clinics are a lot safer, so we have to get them back. So you have a plan to go out and try and recruit those people back into the healthcare system, I would imagine.
Well, the hospital is doing a lot of PR, and we're also demonstrating to people how safe the environment is. Everybody that walks, before anybody walks in the building at the clinic, actually any part of the building, they have to be screened. There are temperature screenings that go on. Nobody comes in without a mask. So, you know, I think it's just a matter of time of getting the word out. As people end up going to the ED, this is a small community. Harlem is a very small community. So once people see that, this person went to the ED and it was really good and they didn't get sick, then they'll start coming back. Besides the asthma population, we have a very big COPD and CHF population. So I think it's just going to take a little time for things to calm down. I mean, I've been watching over the past couple of weeks, it's slowly starting to creep up. Our ventilator load hasn't creeped up yet, but I think part of that was our temperatures have been so mild, except for the last like 4 or 5 days. Now that we've gotten some brutal heat, I think that'll change also.
So you're already anticipating ranking up or ramping up of your demand in the fall with the flu season coming, the other flu, not the COVID-19.
I think that's going to make things a little harder. There'll probably be another surge. We're closely monitoring. I mean, that's why we're still producing data every day, closely watching the patients that are coming in. There's a lot of information that comes out of New York State. So getting people to actually follow the guidelines is sometimes a battle. But I think that our state government and our city government has done a good job of trying to make sure people are following the right guidelines. And that's why we've been able to get that curve to go down. I think also people saw how bad it was. And everybody saw the stories, saw the people that passed on without anybody being with them. When you experience it, I think you don't want to go back to those days. So I think that's why, even though our compliance isn't 100% in this state, I think it's pretty good. And the reason is because of the experience we had.
Well, it sounds like an awful lot of the changes that you implemented were actually repurposing existing policies and procedures and bringing them into the COVID-19 reality. I want to thank you, Michael, for spending time with us. I know you're extremely busy trying to keep your hands on the wheel. You know, it's something that's moving rapidly. We learned quite a bit about how you, the hospital, and your RT staff, for all intents and purposes, reinvented respiratory care services. And I have no doubt that the perception of the importance of the respiratory therapist has gone through the roof in your facility. So thanks again, and congratulations to you and your staff for a job well done, Michael. Appreciate your time.
Thank you very much.